When a patient is better but not clear on a biologic, what is your stepwise approach? Topical optimization, adherence work, combination systemic, dose adjustment, or class switch? And in what order?
So pretty much I always start with everybody with a topical, see how they respond. But I also see the body surface. You can respond, but is it going to be a great effective long term? Getting biologics covered are hard. Otezla used to be a good one, but is that side effect of possibility of depression or suicidal thought? And I'm not saying that everybody gets it, but as a clinician, especially in a community by yourself, you don't have that much backing. You're trying to do the least. Sotiku is a new one that came out, tyrosine kinase inhibitor. It's an excellent drug. It doesn't carry that side effects for people who are more inhibited to doing the injections. And there's some new topicals that are out, like Zovary came out, and it's an actual decent drug that helps to decrease psoriasis. But I still my go-to is Skyrizi. I actually like Skyrizi. It is every 3 months, so you don't have to do it as often, and has a really great clearance rate.
What practical strategies have you found effective for managing erythrodermic, pustular, or rapidly progressive psoriasis in the real world, including when to use cyclosporin or to even maybe hospitalize?
So I must admit, I had one erythrodermic patient, and they're a little scary. You're like, oh, okay, what's going on? So the first thing you want to do is, especially if they have a lot of open areas, is pretty much give them, like I do wound repair. So there are wound repair creams that are out there like Biafin, um, Lexamend, Episerum. They're great creams. If it's too much of a body surface area, that's when you definitely go to the hospital. You're like, you have to go in. But there's some that you can manage, especially if it's not too widespread, and topical corticosteroids. But those management to get that body temperature under control, because you lose body temperature when you have no skin coverage on the epidermis. Pustular, definitely you want to put on some antibiotics with them and topicals to dry up. Like, no, people don't utilize like gel-like corticosteroids, but gel-like ones,
Mhm.
they dry up those pustules really well.
Interesting. Um, how do you handle patients with significant metabolic or cardiovascular risk when choosing and sequencing systemic biologic therapy?
Oh yeah, you want to go for the safer profile drugs
Mhm.
like I said, Stelara, Skyrizi. They're not bad. They're great. They don't really have that metabolic syndrome associated with it. Humira doesn't, and Taltz is pretty good as well. Tremfya is also a good one. So those avoid those side effects from coming up.